Welcome to the Explainer. Today we're jumping straight into a rapid-fire clinical review of critical care and trauma MCQs. We're skipping the fluff and focusing purely on the high-yield facts to maximize your retention. Let's get right into it.
MCQ, Block 1, questions 31 to 33.
Question 31. A trauma patient loses about 3 liters of blood. Which mechanism responds most urgently to maintain vital organ perfusion? The answer you want here is C, baroreceptor reflex. This reflex is incredibly important because it acts within literally seconds of a blood pressure drop, producing an immediate sympathetic stimulation. So you're looking at instant tachycardia and vasoconstriction. For your exams, always remember, the baroreceptor reflex is the absolute earliest response. The RAS system, well, that's for long-term compensation, and the CNS ischemic response kicks in much later.
Question 32. At which value of base deficit does morbidity and mortality increase significantly? The correct answer is E, greater than 6 millimoles per liter.
A base deficit over 6 reflects severe tissue hyperperfusion and lactic acidosis, signaling a very poor prognosis. Clinically, this value is derived from an ABG, and it's a critical tool for reflecting the severity of shock and monitoring your ongoing resuscitation efforts. It heavily correlates with increased mortality, so you definitely need to keep a close eye on it.
Question 33. At which hematocrit value is a blood transfusion required? The right answer is E, below 21%. Now, while 21% is your classic textbook transfusion trigger, the exam pearl here is that the patient's overall clinical condition is actually much more important. Ongoing blood loss heavily influences your decision. Also, be aware that patients with cardiac disease might require a transfusion way earlier, and you should always interpret this alongside hemoglobin. MCQ Block 2, questions 34 to 36. Question 34. Central venous pressure measurement is used to monitor what? The answer is C, intravascular volume and right ventricular function.
CVP reflects right atrial pressure, which gives you a great estimate of right ventricular preload and intravascular volume. Keep in mind, a normal CVP sits right around 2 to 6 millimeters of mercury. It does become less reliable in cases of pulmonary hypertension, though. Oh, and if you need a left heart assessment instead, you'd want a Swan-Ganz catheter.
Question 35. Heparin-induced thrombocytopenia classically occurs after how many days of heparin therapy? The golden number is E, 5 days. In patients exposed to heparin, HIT usually develops 5 to 10 days after exposure. You'll see the platelet count fall by over 50%. Paradoxically, the main risk here is thrombosis, not bleeding. Your immediate action must be to stop all heparin instantly. You treat this with direct thrombin inhibitors, and remember, platelet transfusions are completely contraindicated. Question 36. Which of the following correctly describes the effects of dopamine? The correct answer is B. At high doses, it increases coronary blood flow.
Dopamine's effects are totally dose-dependent. Step 1, at low doses, you get dopaminergic receptor stimulation. Step 2, moderate doses give you beta-1 stimulation, which increases your cardiac output. Step 3, at high doses, you get alpha stimulation. This causes vasoconstriction and increases coronary blood flow, but it also decreases your renal and splanchnic flow.
MCQ Block 3, questions 37 to 40. Question 37. Which of the following is the most reliable clinical parameter depicting recovery from shock? You're looking for C, adequate urine output. Urine output is your best real-time window because it directly reflects renal perfusion and overall end organ perfusion. For adults, your target is greater than or equal to 0.5 milliliters per kilogram per hour. It's a much better clinical marker than just relying on pulse or blood pressure alone. If a patient has oligoria, it strongly suggests your resuscitation is inadequate. Question 38. Which of the following is the most reliable overall parameter to determine recovery from shock? The correct answer is D, correction of base deficit. Correcting the base deficit is the best overall marker because it actually proves you're reversing tissue hypoperfusion and lactic acidosis. It reflects global tissue perfusion. If you see a persistent metabolic acidosis on your ABG, it indicates ongoing shock, and this is far more accurate than just checking their pulse or BP. Question 39. Transfusion of FFP is indicated for which of the following reasons? The correct answer is D, specific coagulation factor deficiency with abnormal PT and/or APTT. FFP contains all the coagulation factors needed to correct multiple deficiencies at once. We're talking factors 2, 5, 7, 9, 10, 11, and fibrinogen. That's exactly why it's used in DIC, liver disease, and dilutional coagulopathy. But definitely remember this exam pearl. FFP is not to be used just as a volume expander. Question 40. Which of the following should be administered if bleeding does not stop intraoperatively in a cirrhotic patient? The answer is C, fresh frozen plasma. Cirrhosis causes a significant deficiency of multiple clotting factors, which leads to a prolonged PT and INR. FFP is the treatment of choice for active bleeding here because it replaces those missing factors rapidly, and the clinical effect is immediate. It's incredibly useful for multiple factor deficiencies, especially since vitamin K alone is simply insufficient. So, after all that rapid-fire review, are you ready to apply these high-yield pearls on your next board exam?